Hi, I'm MBM. Hi, I'm Bason-Mitchell, and we're here today to talk about fentanyl. Fentanyl is a narcotic used for analgesia and pain control in the field. Fentanyl is a synthetic opioid, meaning it is made in a laboratory. We're going to discuss today the benefits and the side effects of it and compare it to morphine, which is our current narcotic of choice for pain control in Marin County. Fentanyl is a very strong medicine. Fentanyl is 50 times stronger than heroin and 100 times stronger than morphine. We're obviously not going to give equivalent doses, so no one's going to say give 4 milligrams of fentanyl, but the conversion of the dosing is one of the things that will be important to understand. The potential benefits of fentanyl are primarily related to the fact that it does not release histamine. Histamine is very much like what gets released when you have an allergic reaction. And morphine releases histamine and then can potentially cause both nausea and hypotension. So it's believed that fentanyl will not cause hypotension when given in the field, which is a particular benefit to older people or multi-system trauma patients. Another big difference between morphine and fentanyl is the duration of action. Fentanyl is a shorter lasting medicine. Morphine sometimes will give pain control for 45 minutes to an hour. Obviously, frequently it has to be redosed. Fentanyl tends to last about a half hour, which isn't really relevant unless you're coming from far away, either because you have a long transport off the mountain or from West Marin. Unfortunately, fentanyl has also been involved with a high number of deaths in the United States and has become a drug of abuse as well. Precautions in using fentanyl are essentially the same as the precautions we have when using morphine. Care should be taken if a patient is hypotensive, has respiratory depression, is elderly, has signs of significant head trauma, and a variety of other precautions that we've been using for years with morphine. Side effects of fentanyl are very similar to morphine, respiratory depression and altered mental status being the most common ones. My experience in talking to a medic that works in Berkeley and has used fentanyl for a number of years, she tells me that fentanyl does not cause nausea, which will be awfully nice, and that's likely in some way related to the lack of histamine release. So it is less likely you will have to give concomitant Zofran always with your fentanyl, but obviously this will take a little bit of trial and error. Fentanyl reversal is exactly the same as morphine reversal. Fentanyl, just like morphine, binds to the opioid receptor. And if somebody gets either too much medicine or begins to have respiratory depression or hypotension, we know that we can give Narcan in incremental doses of 0.4, and that will displace the fentanyl from the opioid receptor, and as we know, also put a patient potentially into narcotic withdrawal, but it will certainly reverse their narcotic effect. Larger doses of Narcan are not necessary for fentanyl, even though fentanyl is a stronger medicine. The trickiest thing for people when they first begin using fentanyl will be the dosing. As I mentioned, fentanyl is 100 times stronger than morphine, and so the transition will be from milligrams to something called micrograms, which is not an abbreviation we're used to using. However, there's a pretty easy way to figure that out. So we're all traditionally used to giving 5 milligrams of morphine in the field. All you do is add a 0 to the 5 and you get 50 micrograms. That is essentially an equivalent dose. So 5 milligrams equals 50 micrograms. Therefore, 10 milligrams equals 100 micrograms of fentanyl. 20 milligrams of morphine equals 200 micrograms of fentanyl. This will be tricky at first, but then in time, we'll get real familiar with it and we won't even have to give it a second thought. Something similar to the slide that you see on the screen will be placed on all units, so in the beginning when this is a challenge, we can all refresh our memory on the dosing. Fentanyl comes as 100 micrograms per 2 mLs, and it can be given in a variety of ways, similar to morphine, except that you can also give it intranasally. So it can be given IV, IO, intranasally, as well as intramuscularly. IV and IO is essentially the same policy, just with the equivalent changes. So in other words, our first dose of IV morphine would be, instead of 5 milligrams of morphine, 50 micrograms of fentanyl, which can be repeated every 5 minutes for a total of 200 micrograms of fentanyl, remembering that that's the same as getting to our max of 20 milligrams of morphine. Intranasally, the dose is a microgram per kilogram, which is then split in 2, and each half dose is given into each nostril. One of the benefits of intranasal fentanyl is that you have an awake patient. We're all used to giving intranasal meds in the field to either seizing patients when they're getting Versed or narcotic overdoses who are getting Narcan, so they're not cooperative. One of the benefits of using intranasal fentanyl is you can have the patient cooperate either by blowing their nose first or actively sniffing when you're spraying the medicine in their nose. I believe everybody will be a little bit nervous when they first give a young person intranasal fentanyl because it's a new medicine, new dosing, it's a child, and it's a new route of administration because it's intranasal. However, I use this medicine intranasally in the emergency room all the time. The other nice thing is you can give the first dose in one nostril, wait a moment, see that you've gotten some pain control and then the patient doesn't have respiratory depression, and then give the second dose in the other nostril. Intramuscular fentanyl is a little bit more of an unknown to me because we don't give a lot of intramuscular fentanyl in the emergency room. I plan to start to give this more often just to get a little better sense of the cause and effect. However, if you can give somebody a medicine intranasally, why would you give it intramuscularly? So I'm going to suggest trying to use it intranasally as often as you can. One more word on intranasal fentanyl. This is really a benefit for children. Obviously, parents don't like to see their children in pain. Children do not want a shot. So the benefit is if you've got a child or a young person with a fracture, you can give them intranasal medicine, their pain will be well controlled, and they won't have to have a shot, which will make them happy also. Fentanyl has been added to the color-coded dosing chart, and it will always be a good idea to go over your dose with whoever you're working with. We use essentially exactly the same policy we use for morphine, only we're going to substitute fentanyl for it. So as some examples, if you reach the maximum dose of 20 milligrams of morphine or, next year, 200 micrograms of fentanyl, and you feel the patient still requires pain control, you can call the emergency room, explain that very clearly, and likely you'll be able to give them more medicine. Other examples where you need a consult is required: multi-system trauma, severe onset of headache because of concern about deterioration of neurologic status after getting narcotics, women in active labor, patients that are also going to get benzodiazepines, and the same rule goes with morphine as it does with fentanyl. If you're going to combine them with benzodiazepines, be very careful because the combined sedative effect can cause problems. Lastly, patients with low blood pressure need a consult as well. Like any change in our system, an important thing will be realizing that this will be a new medicine, and people will be a little bit nervous giving it initially, so be careful to check the dosing. Have your partner check the dosing, and then as we get more familiar with it, we'll be more comfortable with the way we use it. You're always welcome to come and ask me questions, as well as asking questions of the nurses and doctors in the emergency room, as well as our EMS, CQI, and education team. Be careful. Thank you. And I want to thank the Academy. This is MBM, signing off. Can't you see that I'm on film?